6 different forms or categories of tachyarrhythmias. In no particular order, they are sinus tachycardia, atrial fibrillation, atrial flutter, multifocal atrial tachycardia, supraventricular tachycardia, which is an umbrella term inclusive of more specific rhythms with confusing acronyms like AVNRT and AVRT, along with something called atrial tachycardia. And finally, there is ventricular tachycardia, which can be subdivided into monomorphic and polymorphic subtypes. I'll go through each one at a time, but while we're on this screen, I want to point out that the first 5 rhythms on this list typically have a narrow QRS complex, unless one of the following is present: an underlying bundle branch block, pre-excitation, a condition in which a patient has an abnormal bundle of conductive tissue that connects the atria and ventricles, bypassing the AV node. Although not strictly correct, this is often used synonymously with Wolff-Parkinson-White or WPW syndrome. Use of drugs which prolong the QRS complex, most notably class 1A and 1C antiarrhythmics, such as procainamide and flecainide respectively. And the last, profound hyperkalemia. Ventricular tachycardia, on the other hand, always has a wide QRS complex. I'll first focus on sinus tachycardia. On EKG, the hallmark features of sinus tachycardia are first, that it is regular. Second, the P waves are clearly discernible before each QRS complex, with identical morphology to normal sinus rhythm. Sinus tach develops over minutes to hours, rather than over a few seconds. And the rate is usually variable over time, rather than being fixed. The next rhythm is atrial fibrillation, usually abbreviated AFib. It is the classic irregularly irregular rhythm, meaning that it is both irregular and there is no repeating pattern to that irregularity. The atrial activity as visible on EKG consists of irregular, low-amplitude undulations, often called fibrillation waves or F waves with a lowercase f. Those undulations can sometimes be unusually prominent or seem more organized, but as long as they are occurring at a very fast frequency and have variable morphology, it is still best to consider the rhythm AFib. Unlike sinus tach, which occurs gradually, AFib develops very abruptly. One moment the patient is in sinus rhythm, and then he or she is instantaneously switched into AFib. Like sinus rhythm though, it too can have a rate that varies dramatically over time. Sometimes AFib will fall into a tachycardic category, sometimes the rate will be normal, and rarely it will be bradycardic. Bradycardic AFib implies severe AV node disease or an excessive dose of a medication that blocks the AV node. Atrial flutter, the ventricular activity, that is the pattern of QRS complexes in a flutter, can either be regular, regularly irregular, or irregularly irregular. Atrial activity consists of regular sawtooth waveforms, most prominent in 2, 3, and AVF, along with upright deflections in V1, which occur at a rate of 240 to 340 beats per minute. The rate of atrial activity, often referred to as the flutter rate, is commonly right at 300 beats per minute exactly. This very rapid atrial activity is sometimes referred to as an F wave with a capital F. Rates slower than 300 are typically seen in patients with very enlarged atria or those on class 1 antiarrhythmics. Rates faster than 300 are typical only for patients with unusual flutter circuits. The way I think about this is that the speed of a reentrant rhythm is largely dependent upon the physical size of the reentrant circuit. Therefore, as long as a patient has the same location as typical for the circuit in the right atrium, as long as the right atrium is normal in size, it makes sense for the flutter rate to be about the same. Usually, 50% or more of atrial impulses are blocked by the AV node. So for example, if the flutter rate in the atria is 300 beats per minute, but every other atrial impulse is blocked by the AV node because of the AV node's refractory period, then the overall ventricular rate will be 150 beats per minute. Like AFib, a flutter develops abruptly. And finally, the rate can vary over time and can demonstrate abrupt discrete incremental changes associated with abrupt changes in the degree of AV block. Let me show you three variations of a flutter. First is a regular ventricular response. In this case, a consequence of 2:1 AV block producing a ventricular rate of 150. It's not very common, but on occasion, AV block in a flutter can manifest an interesting pattern in which 4:1 AV block alternates with 2:1 AV block in a repetitive pattern, resulting in a regularly irregular ventricular response. If the atrial rate is around 300, this pattern will result in a ventricular rate of around 100. Very astute viewers might note that in this particular example, the second QRS complex in each pair here comes ever so slightly late for a pure 4:1 alternating with 2:1 block, which is fairly common to see in this pattern. And a flutter can also have an irregularly irregular pattern, which can mimic AFib if the flutter waves are very small, or if the rhythm is being evaluated on a telemetry monitor, which often do not capture atrial activity with sufficient resolution. The next rhythm is called Multifocal Atrial Tachycardia, abbreviated MAT. Of the 6 categories of tachyarrhythmias, this is the least common. There are 3 EKG characteristics that define MAT. First, it is an irregularly irregular rhythm. Second, there are 3 or more distinctly different P-wave morphologies. And third, there is no one predominant P-wave morphology. If there was one predominant morphology, a more accurate description of the rhythm would likely be sinus tach with frequent multifocal premature atrial contractions. Let's look for those different P waves in this example. Here's the first. Does this morphology show up later in the rhythm strip? Yes, I think it does right here. Then here's the next P wave morphology, which seems to recur here. And this unusual appearing sharp negative P wave appears to be the third morphology, which I think gets repeated here, here, and here, though some of these may actually be different. And here's the last unique morphology, here and here. So in this 6-second strip, there are at least 4, maybe more morphologies, and hopefully you agree that none of them seem to be predominant over the others. The 5th category of tachyarrhythmia is Supraventricular Tachycardia, abbreviated SVT. This is a strange term that doesn't exactly mean what you might guess from its name. After all, sinus tach would seem to be a supraventricular tachycardia, since it originates from above the ventricles. They are all highly regular. The rates tend to be in the neighborhood of 150 to 200 beats per minute, but can rarely be as slow as 120 or as fast as 250. The P waves may come before the QRS, after the QRS, or not be visible at all, meaning they occur simultaneous as the QRS. When visible, the P waves usually have an abnormal morphology consistent with either an ectopic atrial focus or retrograde atrial conduction. Most, though not all, SVTs begin abruptly, and the rate is usually, but not always, very constant. Here are 3 examples of SVTs. In this case, there is a very short 9-beat run of an SVT in which the P wave comes before the QRS complex. Notice how the P wave morphology during the arrhythmia differs from that when the patient is presumably in normal sinus. Here is an example in which the P wave comes after the QRS complex, and notice that it has an upside-down morphology. If this were a recording of an inferior lead, such as 2, 3, or AVF, which this could be, we would call those retrograde P waves, meaning that the wave of depolarization in the atria is moving in an inferior to superior direction away from the AV node and towards the sinus node. And here's an example in which the P waves are not visible at all. The final rhythm I'll discuss today is the most dangerous, and fortunately, usually the most obvious: ventricular tachycardia, abbreviated VT. VT commonly has a single QRS morphology and is usually regular. This is called monomorphic VT. It is common for the first handful of beats of a monomorphic VT to show some irregularity. VT can rarely have multiple QRS morphologies, in which case it's usually irregular. This is called polymorphic VT. VT always has a wide QRS complex and almost always is greater than 140 milliseconds in width. And though it's a minority of VT EKGs which show this, if you see evidence of AV dissociation, fusion beats, or capture beats, when these are present, it is essentially diagnostic of VT. For those viewers who are unfamiliar with the term AV dissociation, this refers to the situation in which the atria and ventricles are not communicating with one another. On EKG, this is evident as P waves and QRS complexes occurring at different rates and which appear completely independent of one another. AV dissociation is much better seen in complete heart block, and even when present in VT, it is usually only a rare dissociated P wave that will be visible between the wide, rapid QRS complexes. Here's an example of monomorphic VT. This little bump on the downslope of the second T wave is suspicious for a dissociated P wave, in other words, evidence of AV dissociation. And here's a classic example of the much rarer polymorphic VT. This is its most well-known subtype, something called torsade de pointe, which is almost universally caused by a prolonged QT interval. So those are the 6 basic types of tachyarrhythmias.
Hope you liked our video. Share this information with your loved ones. And don't forget to subscribe to our channel. Thank you.